So it really is the concept of it sounds like a very, very multifactorial complex model that we're dealing with. We're thinking about what initiates or triggers the immune response, what's actually perpetuating the immune response, because as Raphaela nicely mentioned, there might be very different things about sustaining the immune response versus what actually triggers it. And then ultimately the end organ damage and what's unique about the lung in systemic JIA. And is it actually unique in SJIA, or are there commonalities from other inflammatory rheumatic diseases that we can learn from? So I think those being new to, and thank you for the invitation to join this meeting, but being new to this kind of little family here, those are what I would have taken away from this session. So with that, I'd like to open it to the floor to ask some questions.
May I ask?
Yeah, sure.
Ask you. So you mentioned this heterogeneity of macrophages, and sort of our single cell data does suggest that we may have distinct population of macrophages. So you describe pro-inflammatory, anti-inflammatory. Do you think it's possible that in the same tissue we can see coexisting pro and anti-inflammatory distinct population of macrophages? And if we design a therapeutic intervention, is it possible that we are targeting one population but at the same time harming the other population?
So I think definitely you could find probably both populations by your single cell seq. So there have been examples of looking at initiation and resolution of inflammatory responses using single cell seq, and you'll find, I think there were 5 different populations. 2 that it was just in JCI Insight related to an LPS injury model, and they found 2 populations of tissue-resident alveolar macrophages and 3 of monocyte-derived alveolar macrophages, and they varied over this was in a mouse model, so they knew the time course of the inflammatory response, and it was, as you would expect, a dynamic process that changed with initiation and resolution of the event. So I think depending upon where the patient is in terms of the chronology of their lung disease and the treatments will affect what type of single cell or subpopulations of macrophages that you find. So yeah, I think that's highly likely. And if you could, I don't know the answer to this, but if there's a way to promote the homeostatic tissue repair resolution part of the pathway, that would be ideal. And for example, there are pro-resolving lipids that have been identified that mediate resolution of inflammation, like lipoxins, resolvins, and those type of things. So maybe there's a two-pronged approach where trying to lessen the inflammatory burden, but also trying to promote the resolution of inflammation.
Rashmi, go ahead.
Are you aware of, you're talking about pro-resolvin and targeting it that way, are you aware of linabasum, corbus, which is, Alexei, you might be able to describe what it is.
It's something that actually interacts with the cannabinoid receptor. And I think it was identified as one of the resolvins, and I don't remember exactly what model. I think it was skin inflammation more than anything else. And I think there is a company, startup company in Massachusetts and Boston. I think they are called Corbus, and they have clinical trial of that particular molecule that stimulates cannabinoid receptors in systemic sclerosis, if I remember correctly.
And in cystic fibrosis, so both in rheumatic diseases and in pulmonary diseases, and in cystic fibrosis, it's really targeting the lung inflammation.
Yeah.
And they had a pretty,
There were a couple of posters at the EULAR meeting in Spain, in fact, specifically some results of the clinical trials, I think.
Yeah. Maybe I can send you that by email. I would love your opinion about that here.
Yes, go ahead.
So this is for Dr. Levine. You mentioned.
If I didn't take the mic, bagel.
You mentioned about the more local delivery of the drugs. Do you, from a technical perspective, and I respect that this might be something that you may want to defer to other specialists, but in your area of expertise, do you foresee that local, like aerosolized delivery of the biological cytokine targeting treatments become something to basically pursue or being pursued at this point in time?
So, I mean, anytime you can direct the delivery of agent to the organ that's involved, it could have potential benefits, provided that the target cells are localized to that organ. So I don't know in the case of this disease whether that would be beneficial or not. I'm not aware in asthma or other lung diseases of trying to deliver the biologics directly to the lung. I'm not aware of any cases like that.
How about models similar to CAR T-cell therapy? Like delivery more local through like T-cell delivery. Is that something that has been looked at in asthma models, for instance?
Yeah, I'm not familiar of trying to deliver CAR T cells to the lung either. So it's hard to get molecules and proteins through the lung. For asthma, you can deliver albuterol to activate beta agonist receptors and steroids and antimuscarinics, but that's about it. To deliver proteins, then you have there's a barrier function that's pretty significant. So it's been a barrier to the thought with that was initially related to like gene therapy for cystic fibrosis, right? The airway's right there. If you can deliver the construct to the airway epithelial cells, then you could, correct the monogenic defect. And there's a thick mucus membrane or mucus layer that lines the airway epithelium throughout the lung. And the point of that is to clear any exogenous matter that comes into the lungs for host defense. So I think to overcome those host defense mechanisms are going to be problematic or are going to be challenging for anything but small molecules.
I have a question for Raphaela. I was puzzled and intrigued by the downregulation of those three genes, which
This
had
was protein.
protein.
That was protein from a
Apologies.
BEL.
Protein. So
Before and
even
after.
more relevant, which had NFKB motifs. Did I get it right?
So these were, okay. There were two threes. One was basically the proteins in the lung, SCF, and I3 and
No. I'm
MCSF,
talking
and then
about
the other one. So
those
these
are
are
genes. Okay,
These are
got it
genes.
right.
Yes. Sorry.
So they're genes. They are NF-kappa B induced.
They can be induced by NF-kappa B activation and by STAT. So basically, you have each gene has a promoter region, and it can be activated by a number of different things. So what makes the interferon response genes is because STAT1 is basically the major activator through the interferon receptor.
Because they have STAT1 binding sites.
It's not that we looked for STAT1. We did this because we saw this weird pattern, but we clinically actually found them because they were elevated in a patient who actually, a hepatitis patient who got interferon alpha, and also in candle patients. So we selected them in an unbiased way. But then when we retrospectively looked at them, all of them have STAT1 binding sites. And when we started seeing this weird pattern that 3 behave different in one disease and not in the others, we started to go back and say, what else do they get activated by? Because that's not just interferon. And that's how we found that they had NF-kappa B binding sites, therefore can be activated by NF-kappa B and by STAT1. So basically through interferon signaling and through TNF signaling, they could be activated.
Right.
And so we then went back and looked for some genes that only had NF-kappa B, and we validated them. So basically, this is a set of genes that would be elevated by interferon and or TNF, for example.
Right, but they are decreased in patients with SJIA MASPP?
No,
or I got it right?
they were not. They were actually as high as they were in
as high,
Candle and
yes. I
Savi,
missed
right?
that.
But then overall, the interferon response genes, they could actually vary. If they had infections, they were actually higher than when they didn't. So that ratio actually ended up being normal. And the normal ratio comes from healthy controls who don't have an elevated signature at all. It is just that it happens to be that the ratio when you have normal expression of these genes happens to be right in that window between when you have elevated ones and it's mainly interferon driven, the ratio is really low. As we find, actually we have looked at lupus, we've looked at JDM, we've basically looked at Icardiogodia and Savi Candle. They were a little bit in there. All of them have low ratios, but those patients who have that NEMO splice variant or LRBA, who basically also only have partial responses to the JAK inhibitors, tend to have more signaling, seem to have this ratio converted, suggesting that they have more NF-kappa B signaling compared to interferon signaling. So it's a relative ratio. You can just use this as, I mean, we didn't design it that way. We wanted to find interferon signaling, and that is something we stumbled on when we basically started to see that the pattern expression is different. Does that make sense?
It does, but I have to, I mean, it takes time a little bit to digest it.
Yeah, okay.
It takes a little bit, I'm sure you need more genes. I mean, it would be nice to actually have, you know, a set of genes that would be typically NF-kappa B induced, a set of genes that would be typically type 1. The type 1 and type 2, unfortunately, do really overlap.
Yeah.
And so does your P38 MAP kinase, because what you're showing is NF-kappa B are also P38 MAP kinase.
Right. Yeah. Yeah, so.
I'll try to be quick. First, I have more of a statement, and then I have a question, unfortunately, for you, Dr. Levine. So the first is, you know, we just got it was an amazing talk about, you know, antagonizing the inflammation and agonizing or helping the resolving factors. And there's a drug that every one of your children has been on that is sort of the notorious best actor of doing that, and that's corticosteroids. And so one you know, option is, the problem with corticosteroids is not that they don't work, it's that the side effects are horrendous. We haven't really talked about the potential for early use of inhaled corticosteroids in patients with systemic JA who either have not developed symptoms or who are at high risk, if we could identify high risk, but that's more of just a statement of saying steroids work well, inhaled corticosteroids have a nice safety profile, and that's something that we can think about. The other is that a couple years ago at the same conference, we talked about what ostensibly could be the next miracle drug, vamorolone, which is supposed to be a new steroid that does all the good things and none of the bad things. And so, you know, I haven't kept pace of the clinical development of that, but it is in phase 2 and 3 in a number of diseases that are not typically rheumatic. It's an IBD and Duchenne muscular dystrophy, but one, does anybody have any updates on how that drug is doing? And then my question is, what is so different about an alveolar macrophage that has set up shop inside a lung, whether it's yolk sac derived or whether it's monocyte derived? Because you just said, Dr. Levine, that when they do these studies where they get rid of the alveolar macrophages a bit, they bring in some monocyte derived macrophages that fill that niche, but they're more contributory to fibrosis. And the reason I bring that up is that some of the data that I'll show from these patients is that they have a sort of preponderant elevation of MCP1, which is CCL2, which is a chemokine that ostensibly would bring more monocyte-derived macrophages into the space. And so if we knew more about what the difference between monocytes filling that niche versus yolk sac-derived macrophages filling that niche were doing, that might give more rationality to blocking that pathway.
Right, so it's the CCL2-CCR2 pathway that's recruiting the monocyte-derived macrophages into the lung that are differentiating into pro-inflammatory macrophages. So I think that's exactly right. So what's the difference about the cells? Why are they programmed differently? That's a harder question. I mean, they're yeah, I don't know if that's known, but there are clearly different populations of macrophages that have different functions, and it's also dependent upon their milieu. So in the setting of health, there's cell-cell interactions that are driving the anti-inflammatory phenotype of the macrophage, and when those are lost in the setting of ongoing inflammation, then the pro-inflammatory stimuli prevail, and then that leads into a alteration in gene expression to a more pro-inflammatory phenotype. So I would suggest looking at the single-cell-seq paper. I forget who the author was, so I can send it to you, in JCI Insight, that really nicely showed the different populations of macrophages. And the other interesting thing they showed in that paper was that some cells had features of both M1 and M2. So that probably works in mouse models where you either stimulate with interferon gamma or IL-10, but in actual people, it's probably not a very good model.
I think one of the big questions is how do you get them out? Has anybody looked if you have these ones that are stuck at a differentiation pace and don't actually move forward, what you can do to them in order to make them, basically what they are doing is they are phagocytosing surfactant, but they are not digesting it. So that lysosomal degradation is not happening. Has anybody looked in vitro what it is? Because that would be one way to kind of move them along.
Scott, you mentioned inhaled steroids. We had multiple discussions in Cincinnati about this approach, and the problem is that inhaled steroids will get stuck in the airway. So inhaled steroids would work well for the airway disease, but I'm not sure whether they will do something to parenchyma. What's your
Well, it depends. There are different delivery systems in terms of the size of the droplets, so you can target where you want the droplets to go. So usually for asthma, they're designed to try to go to the airway, but they could also, get to the alveolus. And even if you're trying to target them to the airway in children with asthma, the problem is they still get absorbed, and you get systemic levels and a decrease in bone growth. So you probably will get some systemic levels with the inhaled steroids. Usually the question is, are you getting enough of a dose in to make an impact? I don't know of other adult interstitial lung diseases where inhaled steroids are used. Usually it's systemic steroids because you need higher doses.
So there's a couple of questions from the floor, so I'm just going to play referee here.
In terms of the functionality of alveolar derived macrophages and monocyte derived macrophages, going back to the GATA2 patients where they develop pulmonary alveolar proteinosis, but in that hematopoietic reconstitution with the wild type, like with a healthy donor, results in resolution of pulmonary alveolar proteinosis. So how much of this pathology could be more alveolar macrophage dysfunction versus a monocyte-derived macrophage causing this problem? And there are institutions that have done transplants for these patients. And do we know of patients with lung disease who had a full donor reconstitution and had a resolution or not? And they had resolution of pulmonary dysfunction. I'm not 100% sure. I wanted to know. I know Cincinnati has done 2 patients. But
I think that's true that at the NIH, when the GATA2 patients get transplanted, that their pulmonary alveolar proteinosis resolves.
But in systemic JA with ILD,
Well, I think the only patient that did get bone marrow transplantation, Rashmi, tell me, it's the girl in Switzerland, correct?
Yeah. So she had lung symptoms, but I think that it was pulmonary hypertension, though they did find ILD2. I'm not sure if the CTs were looked at to see if it was the PAP pattern or not. She did get a bone marrow transplant. Actually, after coming to the next gen, her mother got so scared off that she went back, and her center had quite a bit of experience in it. And it's been a year past the transplant, and she's doing amazingly well. And yeah, she was on oxygen for a little while there before the transplant, and afterwards she was on oxygen for quite some time. But yeah. Yeah, so that's the only patient that I know of. She also tells me that at the same center, there's another patient with SJIA who also had lung issues, and they also transplanted after her. But I think maybe I can connect their doctor to one of you, and you can learn exactly what this is.
Last week, I saw a new patient with systemic juvenile idiopathic arthritis. Patient had had a genetic disease. One of those. Yes, exactly right. And then got a bone marrow. Yes, Hurler syndrome. Yes. And got a bone marrow for that disease. Did well, and a few months later developed systemic juvenile idiopathic arthritis.
You spoke very quickly. Everybody's saying what genetic disease? I think I heard Hurler's.
Yeah,
Hurler's. Okay.
Like the discussion between tissue-resident and monocyte-derived macrophage happens in multiple disease. Like being part of my job profile being transplant, we do transplants for metabolic disease where the microglia in the brain is not actually, it's a very early in the embryogenesis, there is a separate lineage that forms microglia cells. But by bone marrow transplant, we're only reconstituting microglia-like cells that are monocyte-derived. But it still does the function of stopping the progression of neurodegeneration. I'm curious, something similar in these diseases where we talk more about alveolar macrophages, how much of these could be reversed by a hematopoietically derived healthy monocyte macrophage compartment?
Would you know if the macrophages get replaced? Has nobody looked at that in the transplant world? So if you do a BAL, would this actually be self or would it actually be donor? Because that can easily be addressed, right?
So again, we know post-transplant, if you were to myeloablative, 100% myeloid in the peripheral blood is donor. Eventually, the tissue-resident monocyte macrophage compartment, we expect it to reconstitute to be donor. But no one does chimerisms by alveolar lavage and check. They might have done in certain disease, but I'm not aware of.
Actually, I don't know that would. So Pittsburgh's one of the few places that is crazy enough to do paired lung and bone marrow transplants at the same time. It's a new protocol. It's Bolt, actually, is the name of it. Anyway, but I realized that it wouldn't actually answer your question because the tissue-resident macrophages would also be graft. So, but in the mouse world, there's been a lot of research into exactly what conditions cause that turnover. And mice usually live in very clean conditions, and so under those very clean conditions, the alveolar macrophages in adult mouse are pretty much all yolk sac derived. But inflammation really of any sort causes a transition, whether they die or whatever, don't renew as quickly, to more monocyte derived. And so the thought is in people post-transplant that just normal wear and tear of the lungs would cause the monocyte-derived macrophages to be the ones that fill that niche. Which is why I think we need to be a little bit careful, because I don't think anybody knows what proportion of the people in this room have their alveolar macrophages that are still derived from yolk sac macrophages versus, reconstituted through circulating monocyte-derived macrophages. And it sounds like that matters. I mean, the labs I've been in, everybody said macrophages are stupid. They just go to a place and then they get local signals and that's how they get told what to do. But there's clearly some sort of epigenetic imprinting that takes place based on where they start from.
There's also the possibility that once the macrophages are recruited from the blood, the monocytes to the lung, that they'll differentiate as the process resolves into a macrophage that resembles the tissue-resident alveolar macrophage. So the origin may end up not mattering as long as you get the phenotype that you want at the end.
But it still brings up the question whether BMT potentially could be an option, right?
Do you have any suggestions on what is the best way to keep track of what's going on in our kids' lungs? For my example is my child's labs don't match. They're not showing us that there's activity going on in there. I mean, short of bronchium and CTs, is there something that we should be focusing on? Do we need different labs? You mentioned, the normal labs aren't grabbing. Is there something else that I should be doing?
So
I think there's going to be a good talk afterwards talking about biomarkers, but whether it's lung or not.
my only comment is that a couple of things. We think that we certainly would like to avoid chest CT as much as we can. We think that in younger kids, overnight pulse oximetry with a proper analysis of the data over time in particular might be very, very helpful. In older kids, we think that a 6-minute or 7-minute walk, is it 6 or 7? 6-minute walk potentially might be helpful as well for monitoring. Again, those are not terribly precise measures, and in Cincinnati right now we are developing this new MRI approach to track this disease. So the idea is that aerated tissue is very difficult to image with MRI. So, however, if patients inhale xenon, then we actually can pick up lots of interesting things. So when these patients inhale xenon, some of it stays in the alveoli, some gets in the interstitial space, and some gets into the blood and binds red blood cells. So when we do that MRI, we actually can distinguish these three compartments very nicely. So we can quantitate the amount of xenon in the alveoli, in the interstitial space, and amount of xenon bound to red blood cells. And we can do it for every single area in the lungs, so sort of do it in a very quantitative manner. But it's still very experimental. We think we have done now a few follow-up MRIs around. I think the data looks very interesting, and I think that probably will be a way to do that, but at the moment it's not ready for clinical practice. Xenon should be approved by the FDA for adults, but not for children yet, correct?
CO diffusion, is that of any use?
For younger kids, we cannot do it for younger kids. They will not cooperate.
From 6, 7, 8 years?
Yes. But that xenon approach, it's much more precise. So it tells you.
That's not ready approved.
Correct.
So so far, maybe CO diffusion.
Correct. Absolutely. CO, but for Sophia, it's not going to work.
No.
Kids have to be.
I have a question.
I have a question. It seems to me that this is a very complex process, but so there are factors associated with the initiation or the triggering of this disease, but it seems that once it developed, it's a
Self-sustaining.
yes. Because how many patients did resolve actually?
Well,
We heard of course the story of one.
Well, no, it's more than that. Grant will discuss that in his talk.
Okay. So it occurs also to me that inflammation once it developed may not be the main driver at that time, because all of those patients some of them have at least show less inflammation. All of them have been treated with steroids, but it doesn't affect once it is already established. Is there any? Was just. It seems that the lipid or the cholesterol accumulation is an important factor. Is there any? There are drugs that enhance autophagy in any cell, at least in the cancer field. Is there any? Would that be rational to improve autophagy in?
Well, it's true. That's probably true. The cholesterol clefts, to some extent, reflect issues with apoptosis and removal of apoptotic cells, right?
I don't believe clearance of surfactants via autophagy.
So it actually can go back to your steroid, the statin question. I hate to ask it again. I will give the mic to Fabrizio in a minute. But there is actually a lot of effect that some studies, at least in mice, ourselves included, that have actually looked at the role of statins in mediating small GTPases and affecting cytokine production, lymphocyte activation. And now, borrowing experience from other diseases, such as Kawasaki disease, which we heard this morning one of your children evolved from, actually multiple trials using statins to moderate the immune response in Kawasaki disease, of which they are actually effective. So if we're dealing with a final common pathway, at least part of the sustaining pathway, not the final, but part of the sustaining pathway, would it make sense to actually use a not so toxic drug in trying to moderate this disease? Dr. Levine, you're in the hot seat.
Seems like the mic keeps coming back to me. I guess you'd have to test it experimentally and find out, you know. So like cholesterol, you know, there's a large interest in studying immunometabolism and cholesterol pathways mediating the functions of immune cells. So, you know, it's possible. I just don't know without experimental data whether it'll be effective. So I think it's a hypothesis that you could test the side effects. You know, it's pretty safe compared to everything else you're discussing. So I don't know if it's the whole answer, but could it potentially help? I guess so.
Thank you. I'm not sure that you have a trigger and then the disease self-maintains. I think there is always inflammation there. I don't think you have looked at lungs at the moment of triggering of the disease. Actually, we look at lungs biopsy very late after triggering, because there's certainly a subclinical phase of the disease before we even get to the diagnosis, and then we make the biopsy. And inflammation is always there. The overexpression of the inflammatory cytokines is present in the tissue. I'm curious to know more about what Scott is going to present, but I think it's clearly evident that most of these patients have smoldering ongoing MAS, so this is an ongoing inflammatory process that is either systemic, a little, or mainly lung-restricted process, which is inherently inflammatory.
Prahal.
Very stimulating discussion. So this has been discussed in the past, but you know, we clearly see an increase in the prevalence of the SJIA lung disease. And again, are there any new insights on, is it the therapies, the anti-cytokine therapies, versus just recognition and looking for that? You know, what is it, why is it that we didn't see this as much before, or did we just miss them in the past?
A lot of head shaking. I'll summarize. You mentioned this, Alexei, but you didn't expound. You said that you had seen 6 cases from the Cincinnati area that had come to your place that weren't referrals. And I have to say that there are certain places that certainly see lots of systemic JIA that aren't seeing any of this. And so is this IL-1, IL-6 blockade plus histo, or?
Well, true. We certainly do pick up a little bit of geographic clustering of these cases. Sort of the other thing is, you know, obviously biologics potentially could be somehow implicated, right? But on the other hand, last year I was in China, specifically when there to look at these patients with a very, very similar lung disease. I wanted to examine them myself and sort of confirm that it's the same phenotype. They look very, very similar. Certainly I saw those fat fingers. No biopsies, so I cannot be 100% sure that it's the same, but it's very, very, very similar. And absolutely no biologics. I was in Chongqing. IL-1 inhibiting agents do not exist there. Actemra does, but they have to pay for Actemra out of pocket, and really only few patients can afford that. So the patients I saw with this lung disease that to me looked very similar had never been exposed to biologics. Then I accepted, for the same reason I accepted an invitation from Israel in December, and all the pediatric rheumatologists, we were sitting around the same sort of table. I was showing them this data, and the question is, you know, have you seen that? Half of the pediatric rheumatologists there have been trained in the States. In fact, 2 or 3 of them were trained in Cincinnati. So their approaches are very, very different to what we are doing here. They have all the biologics available. The only difference is that in Cincinnati, in the States, we could start biologic right away, right? Mona, like in Veda, if I remember correctly, you were actually trying to avoid using steroids as much as you could, and you kind of went to biologics relatively early, right? Do I remember correct? And that's a rather typical scenario in the States. In Israel, you still need to try steroids first, taper steroids, and then sort of if the disease comes back, then you can use biologics. So that's the only difference. But otherwise, sort of the pattern of utilization of biologics is very similar. Not a single case of this lung disease. Yeah, there is one.
So Bas, who is notoriously start biologic very late. Actually, it's the early starter that I know. You've seen one case. I've seen one case. I went to Russia last week And they have 18 out of 95. 18 with, in St. Petersburg.
Russia is interesting because there is another sort of important historic example that I think Peter mentioned and I keep repeating that. But anyway, so I do remember the times when about 30% of patients with systemic juvenile idiopathic arthritis in Russia were developing amyloidosis and dying 2 years later. And that was the reason for that so-called Russian protocol with Cytoxan, because they were trying to prevent this from happening. So the prevalence of that phenomenon was about 30%. I was in St. Petersburg at that time. It was a little bit high in Siberia. And then sort of if you move west, Finland about 20%, and Germany I don't remember, and England it was about 12%. So that particular complication existed. Zero, exactly. Yeah, exactly. In US, there was not a single case of this. And then sort of that particular complication existed for, I would say, in the 70s and the 80s. I did my first fellowship in pediatric rheumatology in St. Petersburg. I started it in 1987. And I actually picked up a few patients at the very end, I did not see new cases of amyloidosis, but I still saw some sort of residual patients, if you wish. And that complications completely disappeared. And methotrexate was introduced a little bit later, so sort of clearly that disappearance of this complication started well before the introduction of methotrexate. The point is that sort of we have another historic example of a life-threatening complication in the same disease that was prevalent in certain geographic areas. It existed for about 2 decades and then suddenly disappeared. So are we dealing with the same phenomenon?
We probably have one with relatively mild compared to all the cases we have heard this morning which has responded to high-dose tocilizumab IV and just some clubbing and very mild interstitial changes in the peribronchial changes on CT, but clinically doing extremely well. So clearly there's both the severity and also the prevalence of this in the lung disease.
It was at Chapel Hill last week, 3 new cases of lung disease at Chapel Hill.
I think one of the questions that obviously brings up is that of the microbiome and infections. And I think I've been itching to actually ask you about asthma in that regard. I think just to the amyloidosis part on the FMF side, as you're all likely aware, the association of amyloidosis, even with the same genetic mutations, was actually related to the childhood mortality in the respective country, which is closely correlated with hygienic methods. So basically, and as the hygiene had improved, the amyloidosis is getting less. So there's been a really strong correlation, and that does point out, people have actually also put it in context with the presence of tuberculosis in these countries and how much that actually may actually contribute as an independent factor to hygiene. So I think the question I had in asthma, is there actually data available? And I think this disease is clearly triggered by infections in many instances. I mean, there are clearly flares that are linked to certain pathogens. And the question is it just pathogens, or could it also be the load of commensals that are actually in the tract? And what is known about the commensals? In the gut, there's much more known about what's good and what's bad. Is something similar known? And then that whole question of the immunosuppression we provide will likely change the commensals in the respiratory tract and maybe even the corticosteroids. So is there any data that actually suggests that microbiome in the respiratory tract affects the severity of
do biologics that
change
using
them?
favor some of those pathogens that contribute to this?
Yeah, so a long time ago, it used to be thought that the airway was sterile, that there weren't any bacteria there. Yeah, but that's not true. And there is an airway microbiome, and it does change, and it's abnormal in asthma. And, I think that's a great consideration, whether the microbiome in the lung is being modified to either drive or resolve disease, and whether therapies are modifying it. So yeah, the microbiome, I think, clearly could be a contributing factor.
So yeah, I just had just a statement. and a question actually. So, this is very interesting about the distribution epidemiologically of geographically of these patients, around the world, and potentially even in the U.S. And, really want to, and make a plea to, try to create some sort of a registry, at least just a clinical registry to, capture, where these patients are and what phenotype they have, and because people are not enrolling these patients in the CARA registry for whatever reason, and of course we're not capturing the right information. Grant and I are trying to work together to change that, but I think it's really important, and potentially to be able to capture this information worldwide, I think would be really interesting. And I know Scott has been working with microbiome potentially in systemic JIA patients, and I just was wondering how that was going and whether.
Just collecting.
So Fabrizio have the last question.
Well, we did transplant. We did fecal transplantation in a patient with an LRC4 disease. He had a very disrupted flora, and although emapalumab controlled the flare, the underlying inflammation was not controlled. And after fecal transplantation, it did really better. And it was controlled and went off therapy with nothing. And we really don't understand. So the question is, I'm sorry, I apologize in advance. Did anybody try to do microbiome transplantation for the lungs? Can you pick it up? I mean, I have no clue.
It's a hot topic in CF, right?
It is.
I don't know if you guys know these awful CF stories, but there used to be these CF camps, just like we have JIA camp, and they had to shut them down because the children with more advanced CF were colonized with these horrible bugs, and then we're sharing them with the more newly diagnosed patients, and it was bad. And so I don't get out much, but I believe that there's a movie. But yeah, I know Jay Coles, when he was still at Pittsburgh, was interested in this. The issue was, how do you deplete what's already there to make room for the new microbiota? Because the microbiota that's in the lung is, especially if the CF patients, is really antibiotic resistant, so it's hard to clear it. And then how do you deliver a new, delivering bacteria into the trachea seems hard to explain to a parent.
Fecal transplantation doesn't look nice.
But I don't know, Alexei, do you think you can, or Grant, can you comment on the work that David Haslam is doing in Cincinnati? He's done some fecal transplant work in, and other microbiome transplant work in inflammatory disease.
Well, I don't think I'm ready to discuss that.
Well, I vaguely remember his father's actually my boss, was my boss. So it was actually quite striking for IBD, the inflammatory, the fecal transplant for IBD.